And off we go. So welcome to this section around continence management. Again, when you go into your Canvas app, you're going to see that I've put some care plans and other forms on there to help alongside this. So the assessment tools, the care plan, the assessment tools, and the recording stuff's all there. So we're going to start on something very basic, and it's basic language around continence and continence management. And that's because we can use some really poor choice words when we're providing intimate or personal care. So obviously banned words are wee-wee, it's urine. We don't do poo-poo, it's feces. We don't do nappies, we call it incontinence wear. We don't say you've meshed yourself, it's you're incontinent or you're doubly incontinent. We don't call it a willy, we call it a penis. And we don't call them the flower gardens, we call them vaginas. So we just need to be confident. See, it always makes me giggle, that one. We need to be confident with the words that we use, because the words that we are using are nursing terminology words. And I know in care, we sometimes do personal centre it. However, if we struggle in saying those words, the message, the sender-receiver message that the person gets back is that you're not a very confident person. You know, you're worrying about something. And if you're going to go down and put a catheter in my penis, I need to see confidence. I need to see that you've got the courage and the conviction. So language is really important. Now, when we talk about incontinence wear or continence management, we need to be mindful about consent. So again, underlining the theme throughout. And remember, in your policies, you should have invasive care technique policies. So the invasive care techniques is all about working around the vagina and the penis area, and actually what it is we're going to do, how we're going to do it, and the people involved in that level of care. So you must read your invasive care technique policies. Obviously, we know capacity is fluid, and what you're starting to get a strong sense of is the digestive system and the urethra system, urine tract system can cause fluctuating issues with capacity. If I've got a infection in my water, it can cause me to be confused, delirium, or if I've got I'm constipated, again, that can cause a change in capacity. So just because I may or may not have a capacity issue, it can fluctuate and improve or decrease with either infections or constipation. So if we were in a position and we had to give personal care to somebody who lacks capacity, so we're talking about our patients who are living with dementia, in their care plan, we should have a well-written continence plan, because there is nothing more frustrating as a caregiver when you go to help Margaret and Margaret's incontinent and she goes, piss off and leave me alone. And you're like, now what do I do? And the reality is you've got to give her the care, because if you don't, it can cause other risks. But then this whole argument about capacity and consent. So have any of you been in that situation where you end up feeling quite frustrated, where you know somebody is incontinent or doubly incontinent and you then can't care for them?
Yes, we've been many times.
All the time, time. And it does happen all the time. And the reality is, on the very first day that they come to your service, there should be a continence assessment. And in it, it should tell you exactly what to do with that person. So for example, let's say we've got Margaret, she's got dementia, and I'm the nurse in charge. So I will already have done capacity and consent. I will already be able to know, am I able to make an advanced decision for her? And the reality is, if I said to Margaret, look, Margaret, if you're incontinent, do you want us to leave you in it? Or would you rather somebody escort and help you? And I would imagine if Margaret had capacity, Margaret would probably say, yeah, please help me. I don't really want to be going around incontinent and wet, and that's not very nice. Equally, If Margaret lacked capacity, I could go to the next of kin. I could say to the family, look, because Margaret lacks capacity, and maybe I haven't had the assessment, maybe I haven't got all of this information, I could say to maybe the son or the daughter, look, if mum is incontinent, what would you like us to do? Now, 10 out of 10 times, the family member will go, take her and get her changed. You know, no family member wants their relative walking around incontinent or soiled. So normally that's what you're going to get. So the reality is we can go a bit further. We can do a lasting power of attorney. So maybe the home has capacity and consent over that person. Or alternatively, you've got your Doles Act, so the deprivation of liberty safeguards, or now the new liberty protection safeguards. So the LPSs are much quicker to apply for now. So Doles is going, that's gone out the window, and we've now got our LPS. And as an LPS, you can simply write to the NHS or to your local authority, Margaret needs support when going to personal care for the toilet. If she's incontinent, we're going to take her. It is unlikely anyone's going to reject that as a bad idea. And the reality is this should all be done on day one of that admissions, because it is an impossible position for carers to be in when they don't know how to help somebody. And you end up with this massive blame. Oh, you know, she said no, so I left her. And what tends to happen is it's the same carers ending up giving care, because the same carers reject the care, and it's the same carers that go, but we've got to do something. So the reality is this care plan must and should be in place. And if that's all done, you're not having to make it up. You're not having to go, this is what we do, this is what we don't do. And in that care plan, you're going to have some very clear things. It's going to be, if Margaret is incontinent, number one, ask her, you know, to go to the bathroom, or ask her to go to her bedroom. 2, maybe try a distraction technique. 3, maybe you need some low-level holds. 4, do this. And actually, what you'll have is you'll have a care plan that's got a sliding scale on it. So what to do with Margaret if she's compliant, and what to do with Margaret if she's not compliant. And next week's session, you're going to hopefully enjoy, because it's the new Managing and Controlling Aggressive Behaviour framework. So it's a brand new course that's just come out. It came out in April last year. And it's all about restraining and holding people in safe ways to provide care. And actually, a lot of the time, when you are trying to help Margaret, who's got early stages of dementia, and she's fighting you, you're not sure what you can do. You're not sure how to hold her, because you don't want to be accused of grabbing somebody. So this course is designed, this new one, which is, I can't remember the whole name of it, but it's Preventing Challenging and Hazardous Behaviour in Care. And basically in there, you'll see a care plan, and you'll see that there's photos about how you can hold somebody to give personal care without being assaulted, because it is not good enough that carers are being assaulted. It's not good enough. It's down to the care team to write a care plan which is fit and appropriate for that person, and that the care staff can give care without being assaulted. And it's as simple as that. And as far as I'm concerned, it is willful neglect if we do not put those care plans in place. So if you have got somebody who is challenging, and personal hygiene, like going to the toilet, is a risk, it's one of their triggers, then there should be a care plan for it, shouldn't there? It is not good enough to have staff being assaulted because they're trying to do their job. And we know use that.
I want to ask something about this, because in our care home, we're not allowed to restrain people. But is that because we are not trained, or because we just the care home?
So definition of a restraint is what's needed there. So there's, if you are guiding somebody, so if you are following somebody, that's a restraint, because it means they're not allowed to be out of your eyesight. If you guide somebody into a room, that's a restraint. If you hold somebody's hand, that's a restraint. The reality is, where care homes seem to get it wrong is, you're not going to be pinning people down. You know, that's the full-on PMVA stuff. What you can do, though, is low-level restraints that provide safe levels of care. Because The Health and Safety at Work Act 1974 says in law that I must provide a safe working environment for my staff. If you are a hazardous customer and you are likely to hit me, that risk has to be assessed, and there has to be a care plan which is appropriate and proportionate to the behaviour. So in other words, if I know me encouraging you to go to the toilet is a risk, and that's your trigger, that's going to make you angry, then we need to look at how we manage that risk and mitigate it. The reality is, if you are incontinent, I have to do the least restrictive approach. I have to provide you still personal care, because if I leave you in an incontinence pad, you're going to end up with a moisture lesion, you can end up with pressure sores, it's got psychological effects, and it doesn't promote a good well-being for the people around you. So there's a whole heap of ethics around dignity and rights and all that lot. What we have to do is balance the care that I'm going to give you. Does that outweigh all of those risks? And the answer is yes. The problem we have is unconfident people in care plan writing. They're not confident enough to go, these are the techniques that you can use. So for example, if you've got somebody lashing out and hitting you, it is appropriate for you to place your hand on top of theirs. Because you shouldn't be in a position where you're being hit, trying to help somebody. So each technique is individualized, and each hold or each restraint is individualized to that person. Okay, and we use the word restraint not in the fact that I'm going to tie you up or hold you down, but in the fact that I am going to restrict a behavior because it's not appropriate for me and it's not appropriate for the staff. And equally, it could be just as distressing for that person. You know, they're fighting because they're scared. The reality is we have to manage that. Do we manage it with psychological interventions? Do we manage it with distraction? Or do we manage it with medication? If we manage it with medication, that's a restraint, because I'm taking away your right and I'm going to use medication to control that behaviour. The reality is there has to be interventions that are appropriate. And the one that I find the most challenging as a mental health nurse is when you've got Margaret and people are afraid to provide her care because they know they're going to get a slap. And that's not what we should be doing. You know, we should have a well thought out care plan for Margaret. And it might be, look, walk Margaret around a bit, do a distraction, give her a cup of tea, try and choose something to distract her from what it is. However, if after a period of time, let's say after an hour of being in an incontinence pad, I am going to have to move to a nursing intervention. And it may be you need to guide Margaret into the downstairs toilet because there's a lot more space. You may need two carers for this because one person will need to be distracting her upper half while one person removes the lower half to do a pad change. And that could be the least restrictive approach. Once the care plan is produced, it's signed off by the social worker, the nurse in charge, the carers and family. And then you have a safe intervention.
That is kind of abuse if you pull the trousers down.
Of course. But that's the whole point of the care plan being co-produced, because we all have to get to a point where we're not afraid to give care. And where we're at the moment, we're afraid to care for people because we're afraid of, is this going to be seen as an abusive practice? The reality is, if you have a behaviour support plan, and you'll learn about that next week, and it is in her best interest, sometimes we just have to do it. We've got to bite that bullet and do it. Because if we've tried everything else, care still has to be given. So it's, does the risk outweigh the benefit? Can I avoid it? Do I have to do it? Probably for incontinence, double incontinence, yes. But for that, I have to know the Mental Capacity Act. I have to know what the law says. And the law says it's reasonable and proportionate, because if I don't give it, that's willful neglect. I'm leaving you in a soiled state. But I must have the legal framework. And actually, that's why it must be done on admission. Because straight away, you could end up having to guide and hold somebody. And you need to know that you're doing it and you're going to be supported. Does that make sense? So it's not the fact that we're going to take away people's rights. We still produce a care plan in a dignified way, which is meaningful, but safe.
Another, too many questions. I'm taking your
time. That's fine.
If it's only one, service user only once is aggressive, do we still have to do a like risk assessment, or how?
Yeah, absolutely. So even if you've got one customer, so let's say you've got one service user and everyone else is absolutely fine, you would still do a positive behaviour support plan for that.
Yeah, but I mean that person, the same person, only once in 9 years.
Oh, I see. Well, it's risk-based. So is there a likelihood that that risk is going to reoccur? So if the answer is no, then that's fine. If, however, there's concerns, because risk it's a very fluid thing, you know, if there is a concern, a genuine concern, and staff genuinely feel that they could be assaulted or hurt, then actually that's a problem. And therefore there should be a care plan in place. So we would do a positive behaviour support plan to manage that risk. So does that make sense? So what we're saying is a well-structured care plan takes away all of this ambiguity. What do I do? How do I do it? How do I help somebody? And we'll show you those care plans shortly. So you've got a very clear, actually, we're missing this in our home. You know, I need a very simple guided document that says, Margaret lacks capacity, step 1, do this, step 2, do that. And we should all then buy into that. And it's signed off by everyone. Yeah.
This document for the managers to do, or?
So it's down for anyone that's responsible for that person's care. So if you're a key worker, you could do the assessment. Anyone can do. So under the new legal framework for LPSs, carers can now do an LPS. You can complete the assessment. You can say, I think Margaret needs this because every time we go and help her, there's a challenge, there's a fight. And we shouldn't be fighting with people, but we do. So this LPS law that's come in, it came in 2019. It's not enforced until April. I think they're going to delay it, but it's still there. The law is there. What it's going to do is it's going to demystify a lot of stuff, and it's going to make it a bit easier, because what we're saying is, yes, people have the right to be looked after and treated with respect and dignity. That's not what's up for debate here. What's up for discussion is the fact, how do we do it safely so people don't get hurt? And that's the bit that keeps being missed, because nobody wants to put it in writing. Everyone's afraid of producing a good care plan. But
yeah, I'm happy, but I just didn't know.
yeah. So the more, and this is what knowledge does. Knowledge makes it a bit easier for us to go, look, what are we meant to do? You know, because arguably there's a fight on both sides of the coin, isn't there? If you leave somebody soiled and incontinent, that's a risk for moisture lesions, pressure sores, and emotional and psychological abuse. You know, they're going to know that they're incontinent. It's going to be, you know, it's undignified, isn't it?
You know the service user very well, and you know they were going to calm down in about 5 minutes if you leave them.
And that would be part of the care plan. So if you knew that, that's the person sent to it. It could be, look, after 5 minutes, Margaret will actually buy into this. You don't need to force it. It's about going, but Margaret might not. Margaret might be saying no for the next 2 hours.
Mm.
Where's the line? Where do we then go? This is the nursing intervention. So it's about it being produced. This behaviour support plan is produced with everyone. It's produced with the carer, because the caregivers know that person. It's produced with the family and the relatives, so they understand the interventions and why the intervention is being used. And it's signed off by a nurse or a manager, because they're the ones responsibly, or they're the responsible clinicians, you know, in law. The reality is it's co-produced, it's signed off, and that's it. You know, yes, we'll review it, but if that positive behaviour support plan isn't there, then what are we meant to do? And the risk to that is all of what we've just mentioned, the moisture release, pressure source, etc. So there's lots of things that we can do to avoid all of that. Because actually what we want to do, good continence management, avoids all of that situation in the first place. Yeah, happy with that?
Yeah.
So what's reasonable? There we go, we've just covered that. So obviously what's reasonable is about doing the least restrictive approach, making sure that the person is not going to be harmed and are other people at risk. Okay, and the reality is, if somebody is soiled or doubly incontinent, they are at risk of being harmed. You know, it does cause health concerns and problems. And ultimately there is a risk to others, because when somebody is incontinent and somebody else smells it or picks it up, it can be a trigger for them, or they may start to become abusive or aggressive towards the other person. So actually, we can have a bit of insight to how people behave. And if you've got dementia or you've got a cognitive impairment and you haven't got that social skill, and I start calling you out for being wet and soiled, then we've got a real problem going on, haven't we? So there are genuine things there. So what we're looking at is what's the harm and what's the risk? And we have to justify that in law. We have to say, this is why we're doing it, okay? So interventions, as a rule, the rule of thumb, this must be a least restrictive approach. So what is the least that we can do? We should always be able to respect people's privacy and dignity. So again, let's do a guided technique into a side room. Let's do a guided technique into the bedroom. So a guided technique is a restraint, and it's part of a positive behaviour approach. So I am going to take you by the arm and we are going to guide you. So it's called a guided into a room, because actually that's where their privacy and dignity is compromised. If I stand there and argue with you in a hallway or in a room, I'm drawing the attention directly to you, aren't I? And people can see that you're soiled. So it's not appropriate. It should always be agreed on a multidisciplinary level. So if you're going to do a restraint, and I don't care what anyone tells me, you're going to be doing about several restraints when you do personal care: the guiding, the maybe hand holding, the asking them to do things. You are going to be taking away a lot of their rights and choices during this. It must be signed off. You know, it's not we're doing this because it's abuse. We're doing this technique because we've used this technique because.
But if you only ask them, is that a restraint?
So if you ask them, that's fine. You could say, look, I can see that you need to go to the bathroom. Can I help you? And if they go, that's fine. The problem is we're talking about those that don't want to go. We're talking about those where you're in that situation, and no training ever addresses those customers, do they? Nobody wants to deal with the challenging ones. But the reality is, I may have to guide you. I may have to put my arm around you, tap you on the shoulder and guide you to a safe space. So if I do that, we must all agree that that's the right approach. It's not just because Stephen said, it's because a group of people have come together and said, this is proportionate and right for this person. Because like you said, it may be that in 5 minutes, Margaret's going to go anyway. Fine, that's stage one. So we're going to have stages and scales. Consent should always be sorted, and especially from others. So again, that's part of the multidisciplinary approach. And consider a positive behaviour support plan. And that's what we're going to cover next week. So we're going to look at that in a lot more detail, and I'll show you the photos and the images and all of that lot you can use. And there's a wonderful site where you can get all of these images about the right holds and how to do certain things to different people. So that behaviour support plan is going to look different for every customer. Yeah, depending on the level of distress and how it works. Any restrictive practices, even as minimal as hand-holding, is a restraint, and therefore restraint reduction network standards must be implemented. So the restraint reduction network standards was the change in the law last April. Okay, so if you want to Google that, you'll find a big document. It's about 400 pages long, and it was all about reducing restraints in care. Okay, so it gives you a very clear definition of what restraints are. Any form of restraint, both direct and indirect, must be justifiable. So an indirect restraint is, I'm going to follow you to the toilet because you can't do it without my help. And that is a restraint because I am taking away your fundamental right to privacy and dignity under the Human Rights Act. So we're restraining anyway, we just don't know we're doing it. Yeah, so again, must be justifiable. Unfortunately, Margaret's got dementia. She's not going to understand the instructions, therefore I need to follow her. That's the justifiable bit.
What about if you say, I'll be behind you to protect you? I don't know.
Yeah, if you're following them, it's a restraint. Because if I said to you, would you like, it's been a while, do you want to go to the bathroom? You're going to be like, Steve, I can do it myself. Yeah. If I followed you, that's going to make you feel quite uncomfortable.
Yeah.
Because you have the right to refuse care and treatment.
Yeah. Mm-hmm.
So it's this balancing act of what's proportionate and right. And that's what the law says. So again, if I say, look, I am going to have to follow you, let's say you've had surgery and I know you've got low blood pressure and you're on, you know, you're on a warfarin something, and there's a real possibility you're going to pass out and whack your head. It's justifiable for me to say, look, I do need to follow you on this occasion. But that restraint may only be limited. It may be for 24 hours. It may be for a day. It could be for a week.
Yeah.
The reality is, if we're going to do it for a long period of time, it's a restraint. It's as simple as that. So we do need to be looking at that. And actually, if you're already in for the penny, in for a pound, you might as well plan out what that nursing intervention is going to look like and look at how things can go from bad to worse quite quickly. And there are techniques as well now for, so I worked with a practitioner in December and we did a lot of techniques on how to nurse somebody in bed. So, you know, when they're kicking out and scratching and you've got those end of life customers with dementia. So we covered all of the restraints in which you can do safely to provide care. So there's holds in which you can do. So if you pass somebody on their side and you roll them over, actually, if you roll them over and hold that arm, they roll on that arm, they can't hit you because they're naturally laying on their arm. It's a restraint because you know, they're not allowed to move, but it's proportionate because you're not holding them and it's their body weight that's holding them. There are blankets in which you can bring over somebody and it almost cocoons them, so it stops them from hitting. So you're holding the blanket, it's still a restraint because you're stopping them from moving, but actually it's better than you hand holding somebody because you're not going to cause damage. Yeah. So lots of things you can do there. The problem is most of this comes from restrictive practices. It comes from personal care, invasive care, because that's the bit we're going to fight. That's the most undignified bit. It's the bit where you normally get the behaviours, isn't it? Really, personal care is always the time where you're going to get challenges. So, okay, so we've got Bob, he's 45, he's got Korsakoff dementia. When you attend him at 9 AM, 12:30, 4:30 and 6 PM, he's always incontinent and soiled. You ask to help, however, he always refuses and you notice a pressure sore is starting to come. Okay, so you've got Bob, he's quite young, but it's alcohol-related dementia. Each time you see him, 9, 12, 4 and 6, he's always incontinent. You can see a pressure source coming, so you've got a risk here. What processes need to happen to ensure both is not at risk for developing further pressure sores or moisture lesions? So what can we do here with Bob around continence management?
We need to know if he's got capacity or no, first of all.
So he hasn't, because he's got Korsakoff dementia. So he's got alcohol-related dementia.
So we have to act in his best interest.
Yeah. So you're going to work in his best interest. What could you do, though, just to avoid him being incontinent? So if you're always going in at those times and he's always incontinent and soiled, what could you do? Least restrictive.
Use the bathroom.
Yeah, so you could look at strategies beforehand. So if he's always soiled at 9 AM, then actually let's go and see him at 8. To
be wet.
Yeah, absolutely. So you're looking at, if he's always wet at this time, maybe we need to bring it forward.
Yeah.
Because actually it could just be the case, because he's got Korsakoff dementia and he hasn't got the signal going to his brain. It could just be that simple adjustment of going to him at 8 o'clock. Morning, Bob, do you want to use the toilet? Could save him being incontinent at 9. Then at 12:30, which is normally the lunch round, at 11, we could go, look, Bob, do you want to use the toilet? So a simple strategy change could improve continence care. Or alternatively, we could have reminders, we could have it on the card, we could use assistive technology, we could have iPads or whatever. But we need just to look at other ways of promoting incontinence care and not just going, but you're wearing a pad, so it's all right. Which is the one that I can't bear. So what documentation should then be presented for care staff for them to follow and understand? So what you'd expect to see a well-written care plan, wouldn't you? Here's his incontinence plan. This is his management plan. Let's see if it works. And the whole point of healthcare, if the care plan doesn't work, review it and keep changing it until it does work. Yeah. Unfortunately, it takes work, it takes time. Okay, so let's just see. Oh, that's not going to play. There's a video, actually, you can watch this on Canvas. It just runs through the basics of urinary incontinence. And we're going to look at now some common signs and symptoms of how they kick it in and work. So we've already done the anatomy and physiology. So we've already seen that picture. If we look at a bladder, for example, there's a couple of reasons why we become incontinent. Okay, the first reason is that muscle wall has just stopped. You know, the muscles are gone, it's just going to leak, and therefore you're going to be incontinent. Yes, you could do some pelvic exercises to try and tighten those muscles back up, but the reality is, if those muscle walls have gone, it's probably done. The second reason we can become incontinent is because it's the urge, I haven't had the signal, but I now need to run to the loo, and actually we just don't make it in time. So that could be Bob. It could just be those early reminders could prevent that massive bladder overfilling. The third might be that down at the bottom of the urethra, if the muscles there have gone, then you're naturally going to get leakage. So if they cough, they're going to wee, and you tend to be incontinent that way as well. So understanding the medical reason why somebody's incontinent gives you an opportunity to write a good care plan for them. If you don't know why they're incontinent, it's very difficult to write a care plan. If it's just a memory thing, then the care plan will be lots of promoting independence, lots of choice, you know, lots of prompts. If it's a muscle thing, it could be let's work on your bladder and trying to regain it. So there's knowing the reason why they're incontinent will help you write a better care plan.
We won't be able to know as just the carer.
Yeah.
Just the doctor will be able to tell
So
us.
if you have an incontinence patient, they're entitled to obviously an incontinence assessment, and in the incontinence assessment, it will tell you the reason why they're incontinent. So again, you could do a referral. This person needs a referral because they're constantly wet, and actually risk of moisture lesions and all of this lot, which is preventable. So if we did that referral, we understand why, and we can look at better strategies. Yeah. Again, with the men, so again, you can see on there for the man, you've got the prostate gland. So again, if the prostate gland is swollen, it's pushed on the bladder, and therefore that's another reason why men could become incontinent. So it could just be the case of shrinking the prostate gland stops them being incontinent. It could be as simple as that, and yet we just keep them incontinent. So we don't do enough, I don't think we do enough in social care to try and help people with incontinence. It very much is the case, here's a pad, isn't it? Which is sad, because I wouldn't want that. I don't want it for me, and I'm sure you wouldn't want it for you either. So we've already covered the urinary system this morning. Okay. Signs of prostate cancer, we don't need to know that. We've covered all of that this morning. Diverticulitis is, we don't need to worry about that at the moment. That's the bowel.
I think even not the doctors are doing much for them to tell us, because we don't really know.
Absolutely. So these are the 6 types of incontinence. You've got stress incontinence, so that's muscle wall. Like I'm bending over, I cough, and I leak. You've got urge, which is you forget to go. So we can deal with forget to go because we can do lots of strategies there. The overactive bladder basically means, normally what happens is we can retain about 150 mils of water in our bladder, no problem. When we go over that, it starts to leak and apply pressure. So actually, if we have an overactive bladder, just by prompting someone to go to the toilet more frequently, stops the bladder overfilling. And we know if you're going to give somebody a drink, within the next 10 minutes, it's kind of in their bladder, isn't it? It's there. So if we're going to give somebody lots of fluid, we could then be going, look, maybe you need to go to the toilet now. and we can stop that overactive bladder bit. The functional one is there's no signal. So if the signal's gone, doesn't mean that they don't need to be prompted. If you prompt them, you just replace the signal. You become the signal to the body. Or alternatively, you could put an alarm clock on them, a watch, and just say, you know, every time that bleeps, go to the loo, because that's your body. That watch becomes your body clock, you know, the signal. Overflow is where you have too much, the bladder's overfilled, and therefore it's going to come out. So you haven't had the signal, it just overflows. And the transient one, so when we're moving and we're walking around, we cough or sneeze, we leak. So again, that's muscle repair and different things that we could do there. So knowing the types of incontinence gives you an idea about the type of care plan in which you can write, okay? Short-term decline for continence, usually sudden or recent onset, is caused by, so your DAPers, they're delirium or depression, so I just can't bother to go, or I've got that onset confusion. Infection, so if we have an infection, sometimes that makes us leak because we just don't know. You know, medication, pain, excessive fluid, not being able to move, or impacting constipation. So they're just the sudden reasons why we could start to become incontinent. If we look at the main three types, so the main three types is stress incontinence, and that's obviously caused through leakage or involuntary movements. Urge incontinence, where you've got that sudden, I need to go now, and obviously you don't make it to the toilet in time. And the overflow, it's just where you've got too much in your bladder. So again, you just need to be reminded to go. The stress incontinence, this is what your bladder would look like before and after. So if it's filled and you sneeze or you're doing something, obviously the muscles of the walls contract, and then as they contract, they come back open, and that's when you leak. So again, different things can be done for stress incontinence. There's internal stuff that can be done. There's caps and different things that can go in. There's lots of treatment options out there. So signs and symptoms of stress incontinence is leakage triggered by coughing, sneezing, laughing, lifting, exercising, and straining. We've all been there, I'm sure. Usually when you're standing up, small amounts or moderate of urine comes through. It's normally infrequent because it's not a time thing, it's just when it is. And obviously, if you've got any residual stuff there. And what you're looking there is the bladder, obviously, should be able to expand. If it's overactive, so that your bladder constantly sending that signal, you need to go to the toilet more frequently. So again, it's a muscle problem rather than an inability to control it. So again, different types of body training that we can do there for those. Urge incontinence is where you get that urgency, the frequency, you're constantly going. You go, you wee, but you can't feel that you've emptied your bladder properly. And you know, when you kind of wee and you stop, and you think, oh, have I gone, have I finished? But you feel that there's more there to come out, but it's just not coming out. So again, we're not emptying our bladders properly. And obviously that can cause problems there. And then obviously you've got your overflow, and that's where you've got, it's just overfilled. So we can avoid overflow by not overfilling our bladders and not drinking excessively all in one time. So drinking throughout the day, and there's constant urine toilet breaks. Overflow incontinence looks at dribbling small amounts, slow or weak flows, incomplete bladder emptying, the need to strain, so you're feeling that you need to go but you're not going, and obviously you've got other conditions there as well. So functional incontinence is caused through an impairment of the mind. So a cognitive impairment, obviously dementia is our top one there, and that's because the proteins in our brain, the neuro pathways have been separated, so therefore the signaling's gone. But again, just because the signaling's gone doesn't mean that we stick you in a pad for the rest of your life. We can support you by putting you on a bladder or incontinence diary. We can look at the times when you're more frequently likely to go, and we just put a toilet and care plan around that to reduce the risk of incontinence. It's not a difficult thing. And again, those strategies are seen as the least restrictive options, because actually all of that diarising and planning saves you end up dealing with an aggressive person at the end of it. Obviously, dexterity and problems. So do you remember last week we were talking about the trusted assessor training and all the skills it took to go to the toilet and stand up? So again, it could be something as simple as, do you just need a bar and a rail? Do you just need to adjust their clothes? It could be something as simple as that, and you relieve the problems around incontinence. So again, promoting independence. Is your bathroom a friendly environment? You know, have you got the adaptations and adjustments which makes it easier for somebody to see? Could be prolapses. So again, you could have a prolapsed bowel, you could have a prolapsed vagina, you could have a prolapsed rectum, whatever's going on. If it's prolapsed and it's dropping out, all to do with the muscle walls, trying to repair those lost muscles. And again, things can be stitched back in place. You could have caps and etc. To stop those. And equally for the bowel, so when a bowel prolapses, so you can either get the hernias, the prolapses, or piles, and that's where we're straining. And the reason we strain is because we don't sit on the toilet properly. When we sit on the toilet, we're meant to be in upright position, 90 degrees. The knee should be slightly higher, and then it stops the bowel pushing on the rectum. And again, in the training videos on Canvas, I've done a video on how to go to the toilet properly, because again, we naturally don't encourage good toileting techniques. Constipation, we all know what constipation is. It's obviously a blockage of the stools. We should be using the Bristol stool charts to identify if somebody's constipated. If we think they're constipated, we should be using the laxatives and things to help relieve those constipation. And encourage walking, exercise, coffee, fruit, diet, fibre, all of the things that we could do to make sure that people are okay. So how much water do we need to drink? Between 6 and 8 glasses each time. And obviously the more water we drink, the better the bowel movement, because the large intestines is designed to extract the water. So if we haven't got a lot of water in there anyway, that's why the bowel gets blocked, and that's what causes our constipation. Hopefully you've seen the Bristol stool chart in the past. So when we talk about this, and it's useful to have these laminated in the toilet. So when somebody goes to the toilet, you can say to somebody, what number was it? You know, because nobody wants to go, I had a lumpy sausage. But if you go, I had a type 2, it just seems a little bit nicer, doesn't it? And again, by having these laminated in toilets, it normalizes it for people as well to go, this is the one that we should be in. If it's not that, let us know. So constipation definition, obviously straining, hardened soles, feeling that you can't complete the evacuation process if you feel blocked. There may be a need for manual evacuation. So that's where we start rubbing the bottom cheek. So you could feel, as you rub the bottom cheek, you can feel the impact of that constipation. So manual evacuation may be required. That's where you need to probably do the enemas. And we can kind of rub the bum and you can feel the feces, the blockage, and then it comes out. We don't stick fingers up bums anymore. That process ended a long time ago. And obviously if people aren't going for more than 3 times a week, so that's what we should normally be looking for. Yes.
Yeah, I've seen like doctors when they come in to check for constipation, they press onto
yeah,
the
if you press the abdomen, you can feel it impacted and it's solid.
And how, what you were gonna feel there, I don't know.
So basically, if you touch your abdomen now, it should be slightly wobbly. If they're constipated and you touch it, you can feel it's hard, and that's because the bowel is impacted, it's blocked. But equally, we kind of know. We know if someone's going to the toilet because you just ask them, or if you've got a bowel chart, you can see the last time they opened their bowels. And the reality is, what tends to happen is you might get a number 6 or number 7 motion, and because carers are going, oh no, Bob had his bowels open this morning, oh, it was just everywhere. Well, actually, that's what's called overflow. So, and what overflow is, you've got that impact, and it's the liquid coming out the side. So it's not a proper bowel movement. So we're looking at like the 2s, 3s, and 4s. Is what we want as a proper bowel movement. You know, if it's a number 1, that's not enough to evacuate. And if it's too watery, it doesn't mean that there's not a blockage in the bowel. So you can have what's called the overflow. So it's important we know that we're having proper bowel movements, and that's what's recorded. Obviously, you can see somebody straining, you can see somebody pushing, you can feel the abdomen, that it's hard. And again, afterwards, you should be able to see that. So obviously, sit on the toilet properly with your footstool is really important, because as you can see there, if we lean forward slightly with our knees higher, our bowel and rectum is then straightened and we're not kinking the bowel. When we sit on a westernized toilet, we actually put pressure on our bowel and therefore we can't open it. And that's why most of the time when we go to toilet, you have to push a bit, because actually you're pushing beyond a bend in your bowel. If you sit forward and lean your knees up, you've got a straight line. So prolapses or piles, I'm afraid these pictures just before dinner is probably not what you want to see. However, obviously we're aware if a rectum looks like any of those, that's not pleasant, and all of those would need to be looked at. Obviously a rectal prolapse is where the muscle of the wall comes down and the bowel starts to drop down through the rectum. And again, you'll see that on the stomach care later, you'll see a whole entire prolapsed bowel outside the stomach. Obviously hemorrhoids and piles. So hemorrhoids and piles, again, pockets of tissue that fill up with blood where we're straining or pushing, or we're wiping too hard and we cause tissue damage and it fills up. And obviously when we wipe, we see blood. All of that treatable and all of that preventable. And other rectal disorders. So we've got internal hemorrhoids. So that's bleeding internally, so you can't see it. You've got skin tags, which is quite common in older people, and those skin tags can tear and rupture and be quite unpleasant. You've got your external hemorrhoids there, so that's pockets of tissue filling up with blood, and you've got your anal fusion there, so that's where it all starts to just come together. And again, it's quite difficult. So lots of rectal dysfunctional orders, which can make it difficult for people to go to the toilet. If you do look at a hemorrhoid, you need to grade them because it's useful for the doctor to know. So grade 1, you're just looking at a reddened area, up to grade 4, where it starts to cluster and you've got pockets of hemorrhoids. So if you are going to talk to the GP for somebody and say, I think someone's got a hemorrhoid, it's really useful for you to grade it. We don't need to do that. So incontinence in men, same really as the women. You've got your normal bladder there, you've got your stress bladder, your urge, where it's obviously overfilled, and then your overflow one there. Okay, yeah. So in men, you've got your BPH, and that's where you've got your prostate gland where it's over enlarged. Signs and symptoms of enlarged prostate gland obviously can be really uncomfortable. It's useful for you to know about that. They can feel that they can't empty their bladder properly, that they can't pee properly. It could be the fact that they've got bladder stones forming if the prostate is inflamed and enlarged. And obviously it's really, it can be quite irritating for them. Signs of an inflated prostate as well is the flow of the urine is weaker and it takes longer for them to pee because obviously there's the pressure on the bladder, so they're peeing, the stream just isn't quick. So if a man pees quickly, prostate's fine normally. If it's taken a long time to pee, it could indicate an over a large inflated prostate. Urine flow becomes dribbly towards the end, and obviously frequent urging to need to urinate because they're not emptying their bladder all the time. Men and women get urinary tract infections. We know if we get a urinary tract infection, we can do a dipstick, gives us an idea. When you do your vital signs training in a couple of weeks' time, we'll cover that there. But obviously, if you do have a urinary tract infection, easily treated, we do a dipstick and we can report that. Lots of back pains that people get are generally kidney problems. So it's to do with the flushing and the cleaning. So if somebody says that they've got back pains, it could be a sign of a urinary tract infection. And again, it's useful just to do that dipstick to make sure everything is okay. Causes of UTIs, bacteria, unprotected sex, not cleaning properly, not drinking enough fluids, not keeping their genital areas clean and dry. And the other one that's on there is smegma, which is the build-up of cheese under the penis and the vagina. So if it's not being cleaned properly and you get smegma, not pleasant, you need to clean it. I can see you're looking confused on the smegma one. It's not there, I will put it on there. And it's a very common thing, especially in younger people who don't wash properly. Okay, UTIs, symptoms obviously can include burning sensations, pee being quite thick and cloudy, blood in their urine, tummy pains, temperatures, etc. So all of the stuff that could indicate a UTI, and obviously confusion. Again, same with children, back pains. People with catheters, obviously more prone to UTIs because of the tubes, obviously, that are in the urethra, and they're not being cleaned properly. So thinking about your pee, obviously we should be peeing in one, so we use the hydration colour chart. And again, if you are recording people's urine, you grade it. So again, same thing. And we know obviously the darker the urine, the more dehydrated they are. And obviously the yellow part of the urine is the ketones and that, where the kidneys aren't flushing it properly. So again, it would indicate maybe a kidney problem and they're not being flushed through properly. So you do a dipstick to check kidney functions and stuff. So obviously the more darker we go, the worse it is. Using your dipsticks, we'll do that in our other, the other session, but what you're looking for in those is your ketones and gravity and pH. So if they've got a high pH level, there's a chance that they've got an infection. But again, we cover all of that later. So good person-centered care planning, obviously is really important to prevent urinary tract infections, regular toileting, keep it nice and clean, drink lots, wash a lot, check your pee on a frequent basis. If you have sex, pee afterwards. And obviously make sure that people are clean. Don't use soap on the urethras. You normally have the ProShield sprays, which the ProShield sprays neutralize the pH and make it safe. Don't hold your pee in, don't urge, don't rush when you're peeing, so don't push too hard because you can ruin your muscle walls. Do not wear tight synthetic underwear, such as nylon. Try to avoid alcohol, obviously avoid sugary drinks because that encourages bacteria, and do not use condoms or lubricant gels for sex. If use the right ones, depending on allergies. And actually, as we're doing sex and relationships now in CQC, nobody wants to have that discussion with an elderly person, but we have to have it at times. Treatments for UTIs, obviously they keep coming back. You're going to do the referral to the doctors. Things you can do themselves. Obviously, they can take paracetamol, they can have liquid paracetamol, drink lots, rest, don't have sex until you feel better. Obviously, just make sure you're pushing fluids. Right, moisture lesions. I'm just rushing through sort of similar time, we're really behind. So moisture lesions is where moisture obviously starts storing the tissue, causes tissue damage. Normally mistaken for pressure sores, but moisture lesions are slightly different. Obviously build up of sweat and that lot. The skin guidelines around moisture lesions start looking at the dehydration, things like headaches, thirst, dry lips, tiredness, confusion, blah, blah, blah. And you just need to obviously push those there. So these are your moisture lesion guidelines. So if you are assessing a moisture lesion, this is the NICE guidelines guidance for it. So a reddened area is your first zone, and that you can just use your barrier creams such as ProShield or your Cavalon creams or any of those ones that you've got. If you've got the moisture lesion, it's all about keeping the skin dry and getting the skin to dry out. But obviously when the skin dries out, it can crack and it can bleed. So we want to try and avoid that. Level 2 is your amber, and that's where the skin starts to become really red and sore and maybe patches of blistering happening. Again, use your barrier creams, report it, get your Cavalon creams on there, and use the products for 2 weeks, lots of rest, and seek guidance from the tissue viability nurse. So if you are in an amber with your customers, that's when you get your TV nurse involved. And then finally, your red zones is where someone's also been sat in a pad for a long period of time. The skin has now completely broken down. And that's going to be really difficult because obviously you've got to build up a pH, and it's the acid in the pH that's breaking the skin down further. So that's where you're going to need those more expensive creams and pro-shield stuff. So again, at that point, you need different products, and the tissue viability nurse needs to be involved because obviously the skin needs to be assessed. Okay, so we've got 3 levels of moisture lesions assessments. So in testing incontinence then, we should be looking at a fluid chart, bladder diary, bowel charts, infections, medication, mobility, dexterity, and the environment. We covered some of that last week. The continence assessment looks at onset, duration, what time does it happen? Is it one day at night? Was there an accident? Is it sudden loss? Is it urge? Or are you aware of those loss? And then what you should be doing is obviously recording the fluid intake, assessing when the bowels are being opened, look at any medical history, maybe there's an underlying cause, prostate or whatever. Look at the medication, because some medications can cause irritability, overactive bowels, etc. And then function. You need to carry out an incontinence assessment. So I'll show you those incontinence assessment forms after lunch. And obviously incontinence assessment looks at level of caffeine intake, alcohol, fluid, medication, constipation, mobility, and the environment. Dexterity issues, obviously, dehydration. We're looking at between 55 and 65% of your body is water, and it decreases approximately by 15% between the ages of 20 and 80. You get a reduction in sensation of thirst, so that's why people dehydrate, because actually they don't get that sensation. And obviously you start to get the reduction in kidney functions. And so if you are constantly peeing dark urine, that would be an indication of kidney problems. Avoid fluid consumption can make incontinence worse. So as drinking less can result in urine being more concentrated and more irritating to the bladder. So there are drinks that are useful and drinks that aren't so useful. The reality is, from a fluid point, any fluid into the body is fluid. Okay, we're just saying there are better drinks than others. So if you are trying to improve incontinence, and if you are trying to improve a healthier bladder, then you need to try and avoid the do not drinks that can obviously cause irritation. I'm not going to worry about that because that is on the other one. We're not going to carry on with that. Right, so on that note, we'll break for lunch. Are there any questions on continence management? The time's just flying by today. I'm completely behind. Any questions? Are we happy with that? Good. So shall we have half an hour? Is that okay? Enough time to fill your bladders, empty your bladders, ready for the next part. Lovely. So let's say half an hour, so 1:15.